Please go ahead.
Go ahead.
No, first of all, I need your permission to use this video for educational purpose, since you are in it.
Yes.
So, in your case, we did the anterior cervical discectomy and fusion almost a year ago, correct?
A little better than a year,
Yeah. Practically, we took the bad disc out. Here's the spine. Our spine is made of disc and bone. Bone, disc, bone, disc. This is C2. Usually C1 is here, and 2, 3, 4, 5, 6, 7, and these are the discs. These are the nerve roots that going out. Every single of them go to a certain place. Like specifically, these 3 fingers are C6. So 1, 2, 3, 4, 5, 6. So this is the bone 1, 2, 3, 4, 5, 6. 6 is the one that comes between the 5 and 6. This is the C6. This goes to this finger, and as well some muscle, especially grip, is involved. So based on your exam, we have a good idea which of the nerves are being pushed. And in your case, the C5, 6 hole where the nerve is going out here is narrow. Now, about a year ago, we did ACDF, and you were getting better, but you fell. And obviously, symptom got worse after that.
I believe so, yeah.
Yeah, and in the last few months, actually, you're getting weaker. In a situation like that, where we are already growing here, bone is growing beautifully here, and in the fall, you didn't really break anything, but it seems that this narrowing here is still a problem.
Okay.
In a situation like that, we go from the back actually, because for us to go from the front, we have to go through all the bone that we grew together, and so that's too massive and too destabilizing surgery.
Yeah, right.
Now, this surgery, we call it posterior lateral mass decompression and fusion. What we do, we make an incision in the back of the neck, about in the area above and below the levels that we want to address. In your case, we are going to go in the C. That surgery was in your case, I think, in the C. I have to just look it up to make sure that I'm showing you the right one. The last surgery was C5 to T1. So, and here in this area, what we are going to do, go into the hole here, what we call facet and the foramen, and we will start taking small bites here until we have a feeling that we can pass a small little probe through that hole from inside.
Okay.
Then we know it's open. Depending on how much of this bone we remove, if we remove too much, we are sometimes concerned about that we are destabilizing it.
Okay.
In that case, we put small screws, about 1/2 inch screws, that they go here, 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 and connect them with a rod to stabilize it. But that's all depend on how much of this bone we have to remove. We call that posterior cervical lateral mass fusion.
Okay.
That's the official name of that. And depending on where the symptoms are, obviously we will address those holes, those nerves that we know are narrowed based on your exam, but based as well on the imaging, but based as well on the sometimes neurophysiological studies like IMG and CV. And practically small incision in the back of the neck, pushing the muscle to the side, making a window where the nerves are going out, and then eventually putting screws above and below, and internally adding metal where we take the bone off, making spine weaker. We add metal to make it strong enough to do the job. Now, there are a few things that are extremely important for the what we call posterior cervical fusion. They are very well known and notorious about getting infected, because most of the time is the vascularization the problem, but sometimes as well it's just the fact that you're laying on it all day long.
Okay.
Or they are very, very notorious to get infected. So we have to be cutting the hair from back of the head down, and as well we have to keep it very, very clean. Okay. Additionally, once we go, the first 7 vertebrae in the neck we call cervical spine. After that, we call them thoracic spine.
Okay.
In the cervical spine, if we have to go to C7, and most of the time the next level 71, it's going to be in a hard kind of situation there's too much mechanical stress on it.
Okay.
So most of surgeons recommend if you have to go to C7, don't stop there. Go further down. In your case, we have to go further down anyway because 71 is one of your distances in the problem. But most of our colleagues they agree that the mechanical stress, if you have to stop at C7, would be too much for the C7-T1. So many times, if you have to go to C7, we usually continue to go to T1, even T2, to give it mechanical stability. Because they don't have much motion there. You don't lose anything on the motion. But the small tiny screws that we put in C7, sometimes it's not enough to make it stable. Then we put much bigger screws that go, called the pedicle screw, that go through this structure here.
Okay.
And then they are bigger, and then more screws that can be stable. So in your case, we are going to go in the back and remove as much bone as we need to open up the hole. And most likely we will have to as well add some metal to internally brace it. And you have to be very careful with the infection. And that you as well, in your case, we have to go to T1 anyway, but sometimes, or actually very often, we have to go even to T2, even one level below it. Any question?
No, that actually explains it pretty well.
You got the most extended consent about how it works, and I put it online so you can look at it again.
Perfect.
Okay, thank you.